Good morning, everyone. Welcome to our March AIDS Clinical Conference, our annual 2005 CROI update. I want to start right on time today just because we have 3 speakers and want to be able to give some time for questions too. I'm really honored to present my colleagues today. I really have the fortune of working with them closely in Madison Clinic here in Seattle. And the 3 of them recently attended CROI, but they're also well known to the ECHO community as they teach quite a bit on a variety of topics related to HIV. So we have, I'll go in alphabetical order here, Dr. Budak, who is the Assistant Medical Director at Madison Clinic, among many other hats, including a co-editor of the NHC of National HIV Curriculum. Then we have Dr. Chase Cannon, who also wears many hats. He's a provider at Madison Clinic, Max Clinic, and co-director of the Seattle Sexual Health Clinic. And then Raaka Kumbhakar, who is a provider at Madison and Mod Clinic, our low barrier clinic, where she's also the director of that and co-assistant director at Madison. So I don't want to take too much time away. There's so many things I could say, lovely things about my colleagues, but I'll let them take it from here and teach us about what they learned at CROI.
Okay, I believe I am starting first, so let me share my screen. Hopefully that looks okay. Great. Okay, good morning, everyone. It's nice and early, so I'll be starting us off on this whirlwind CROI tour and talk about updates in HIV prevention and STIs. So this is my disclosures, and then our AETC disclaimer, which will be the same for all of us. So I wanted to start with Mpox. Because there was a presentation, actually 2 presentations on the STOMP study results, which were highly anticipated. So as a reminder, this was a randomized, blinded, placebo-controlled trial that was conducted across 50 sites in 7 countries to evaluate the use of tecovirimat for symptomatic Mpox on the outcomes that you see listed here on this table. So the results that I will review are from the interim futility analysis that the Data and Safety Monitoring Board conducted. So patients in arm A and B were randomized to tecovirimat or placebo, and then the arm C group comprised those people who had severe Mpox or who were at risk for progression to severe disease, and they received open-label tecovirimat. People who were in arms A and B could also transition over to the open-label arm if they worsened. And as you can see from the schematic, samples were obtained and an exam conducted at the time points that you see here. So these are the participant characteristics for the 344 people who were randomized and had lab confirmed Mpox. Most of them were natal males around age 34, and a quarter of people actually enrolled remotely, which was interesting. They kind of, pivoted to be able to accommodate that in this trial. The median number of days from symptom onset to enrollment was about 8, and then the median number of lesions was approximately 9. And 1/3 of people were living with HIV, and 1/3 of people had proctitis as one of the manifestations of Mpox. So as for the top-line results, unfortunately, they did not see any difference identified between the arms, tecovirimat versus placebo, in terms of time to clinical resolution or for the competing hazard of disease progression requiring transitioning to the open-label tecovirimat arm. The cumulative probability of resolution of symptoms by 4 weeks was 87%. And then in the open label arm, the median time to clinical resolution they found was about 2 weeks. So the pretty flat curves there that overlap, unfortunately. They also looked at if the impact of tecovirimat, if there was an impact of tecovirimat impacts clinical outcomes, and if it was different in subgroup analysis. And they found no statistically significant change by the demographics that you see here or by enrollment type, remote versus in person. Based on the hypothesis that, taking tecovirimat earlier might work, they also looked at if the results were any different by duration of symptoms before initiation, and they were not. They also analyzed the primary outcome by the various clinical factors that you see here, number of lesions, HIV status, et cetera. And again, none of these were any different in group analysis. Subgroup analysis. So Summarizing for Mpox in the STOMP trial, not the results that we wanted to see, but that's why it's good that we do clinical trials so that we can get these data. They found tecovirimat was safe, but did not improve clinical outcomes in this population. Shouldn't say US, that also included people from other places with clade 2 Mpox. So no faster resolution of the lesions, and also they looked at viral clearance from skin lesions that was not significantly different, maybe a trend towards it at day 8. So we now have 2 negative clinical trials, including the Palm 007 trial that was conducted in the DRC with clade 1 Mpox. So both of those negative, but we do have the pending Unity trial that should hopefully have results in another month or so. So we'll see what that shows. But for now, we should prioritize people who are immunocompromised for treatment, and likely that will be combination therapy. So like tecovirimat with brencidofovir, but not using tecovirimat as monotherapy. Okay, switching gears quickly, buckle your seatbelts. This is going to move rapidly. So talking about Doxy for STI prevention, this is an exciting presentation by investigators from a hospital-based clinic in Milan, where they've already seen doxyPEP has been effective for STI prevention in their setting. And their clinic's indications for doxyPEP are actually pretty similar to what the US CDC says, but they do suggest that it be used for intensive sexual activity that they define as having more than 5 partners. So because there's a lot of concern in Europe and elsewhere about antimicrobial resistance, they aimed to evaluate how antibiotics were being used for bacterial STIs. So this was a retrospective study of men who have sex with men in their clinic who got doxyPEP from 2022 to 2024. And they quantified the number of days of antibiotic therapy, and they called that DOT, that's how that's abbreviated, per 1,000 person days for doxyPEP users versus non-users. And then they compared the observed DOT for men who used doxyPEP, which included all of the antibiotics that they needed for diagnosed and confirmed STIs, against the DOT that would be expected for incident STIs in the men who were not using doxyPEP. So in total, 754 men were prescribed doxyPEP and 30% reported at least using 1 dose. And you can see in the table here that the comparison from pre to post showed the incidence dropped by about 65%, and that was for all 3 STIs. And then on the right side, the figure shows that for each of the STI therapies, the expected DOT, which is the red diamond, and that's for people who did not use doxyPEP, compared to the observed DOT and the blue circle, which is for doxyPEP users. Overall, the number of days of therapy was 7 per 1,000 person days for the doxyPEP group. And then I think what surprised me and those of us who were in the session was I think you can appreciate in all cases here for doxy, penicillin, and ceftriaxone that the DOT for doxyPEP users was actually lower overall than non-users. So this was mostly driven by the fact that you were saving days for therapy from averted chlamydia. So the takeaway here is that despite existing concerns about there being AMR among doxyPEP users, this strategy might actually reduce overall antimicrobial use by averting incident STIs. So this is data from a real-world clinical setting. Okay, now moving to San Francisco. So Hyman Scott presented an updated doxyPEP effectiveness analysis, and this was an interrupted time series of STI incidents in the pre versus post doxyPEP period for PrEP clients at Magnet, a sexual health clinic there in San Francisco from 2022 to 2024. And STI incidents, they looked at it every quarter, but specifically they tried to look at the incidents 5 quarters before versus after doxyPEP initiation, and then an equal pre-specified period of time for the non-users. So over 2,500 people are on doxyPEP in this study. A median age was 35. 91% were men, and the demographics were fairly reflective of the San Francisco population. And they found that doxyPEP was almost 4 times higher. The odds were almost 4 times higher for incident STI compared to people not using doxyPEP, which suggested, that people who really need it are the ones who are accessing it. And then additionally, from the pre to the post period, there was no change, while there was no change in STI incidence for the non-users and the doxyPEP users, it was associated with sustained effectiveness for STI reduction. And in fact, interestingly, the estimates that you see here are in the lower table. They're pretty similar to the efficacy estimates that we saw in clinical trials, including for gonorrhea, which was surprising. Okay, so to summarize for doxyPEP, use is rolling out in the United States and then in some countries globally, but there's still a lot more that we need to do to get it to those who are interested and could benefit. And what I found, sort of the most compelling was that doxyPEP reduced the use of antibiotics needed for STI treatment in a real-world clinical setting. But this is still a little debatable that, the criteria for most appropriate use may require some refinement and tailoring for individual clinics or populations. Okay, full steam ahead. Lenacapavir. So talking briefly about this for PrEP. So this was, I think, the most interesting presentation on Lin that I saw as a phase 1 study of once yearly formulation of Lin for PrEP. And this studied the PK, safety, and the tolerability, of Lin given as actually 2 5-milliliter gluteal injections. And specifically, they were comparing 2 different formulations, 5% ethanol and 10% ethanol, which I believe was associated with lower viscosity. So they studied 40 healthy volunteers that were aged 18 to 55, had a BMI less than 35, and 20 people were in each group. Their results are already published in Lancet, so feel free to look at that if you are interested. But the table I pasted here was from that paper, has all of the sort of PK parameters if you would like. But the graphs on the right side, I think, are easier to digest and show that after the intramuscular injection, the concentrations for both formulations surpassed the protective levels pretty quickly, and they were higher than the twice-yearly sub-Q concentrations that we saw in Purpose 1 and 2, and that the troughs were sustained much above that threshold for out to 56 weeks, so over a year. But there were injection site reactions that were quite common, as reported in 80 to 85% of participants in both groups. This included pain, bruising, swelling. And then for the second group, there were actually some people who were like walking funny after the injection because it hurt. And then one person who had a syncopal episode. But most of the adverse events the manufacturer said were considered to be mild or moderate. There were no grade 4 adverse events or lab abnormalities. And then in the graphs, you can see that most participants actually reported no or mild pain that usually resolved within a week. But if they did pre-treatment with ice, that actually decreased the pain ratings on day 1 and 2 for the formulation 2 group. So once yearly injection of Lin in the muscle maintained plasma concentration beyond 12 months at levels that we know are efficacious for twice yearly subcutaneous Lin. It was safe, but there were injection site reactions, and those resolved after a couple of days and improved with pretreatment with ice. So they are planning a phase 3 study already for once yearly injectable Lin for PrEP, and may even be able to use a lower dose. So this really has potential for significant public health impact, but we will wait to see how it will be priced, because I think that is really going to affect how we can scale this. Okay, let's talk about cabotegravir for HIV prevention. So we know that it can be pretty challenging to diagnose HIV when people have taken CAB-LA or long-acting cabotegravir. And so this presentation sort of used data from HPTN 084, which was a phase 3 double-blind safety and efficacy study of CAB-LA versus oral FTDF for PrEP for women in sub-Saharan Africa. Among nearly 2,500 patients or participants who attended over 24,000 visits where HIV viral load was used for screening, there were 87 women who had at least one reactive HIV test that required adjudication by a committee, and most of those were determined actually not to be true HIV infection, but 8 of them, or 9% overall, were confirmed as true cases, and the flowchart here shows the breakdown by the PrEP agent that was used. In 4 of the 8 cases, an isolated HIV viral load that was positive. 3 of the 4 of those were in women who used CAB, and the RNA level was actually below the limit of quantification, and so it wasn't helpful in being able to distinguish between a true versus false positive HIV status. And then conversely, women who used FTDF had significantly higher viral loads that were more convincing for true infection, so about 1,000 copies. There were 77 cases with at least one positive HIV test that were determined not to be true infections. And of those, 12 or 15% had a false positive viral load. Most of these women actually had used CAB in the last 6 months, and several had significant delays between injections. And these positive RNA results did actually lead to pausing CAB at some point for all the cases. Then they calculated the false positive rate, the positive predictive value, and the sensitivity of a single HIV RNA test being positive in the setting of CAB use. So with the caveat that there were only 12 cases included, you can see that the false positive rate was quite high, 75%, and the positive predictive value pretty low, 25%. And these estimates varied a little bit by duration of cabotegravir use. The sensitivity was also low at 63%, but again, this was based just on 8 cases. So a single isolated HIV viral load test does seem to perform poorly for diagnosing HIV in the context of CAB use. And most of these tests are actually expected to be false positives because the prevalence and the incidence of HIV is pretty low when we are using highly effective CAB-LA. So the conclusion from this was that HIV RNA may not be the most cost-effective screening strategy and has potential actually for negative consequences, including leading to prolonged PrEP interruptions. Okay, briefly, I want to touch on PrEP for women. So we know that we're lacking efficacy for FTAF for PrEP in adolescent girls and young women. And in the PURPOSE trial, they looked at subcutaneous lenacapavir compared to oral FTVF versus FTAF for PrEP in women. And they found that the FTAF was not significantly different from FTDF or the background HIV incidence rate. So what was the reason for this finding? As has been shown in multiple prior studies, it did seem to be related to low adherence, which was confirmed with dry blood spot testing. And here the presenter showed that 40+% of participants at week 8 had taken less than 4 doses per week, and that adherence further declined over time out to 52 weeks. So then they conducted a nested case control study to examine the association of FTAF adherence with HIV acquisition. And even with what they considered to be medium adherence or FTAF taken at 2 or more pills per week, the odds of HIV acquisition were actually 90% lower compared to those who took fewer than 2 doses per week. And this finding is similar to what the Discover trial concluded for natal males. So the takeaway that I sort of got from this was all but one case was due to low adherence of new HIV. But medium or high adherence to FTAF is actually efficacious for HIV prevention in women. FTAF didn't lead to a delay in HIV diagnosis. There was just one case with emergent resistance that they think was transmitted. Okay, so finishing up, I just want to make one honorable mention, and it was tough because there are so many things to choose from. But I found this poster to be fascinating. So this was investigators from the Harvard system who did a cost-effectiveness analysis of various combinations of medications for OUD among people who inject drugs, along with PrEP for HIV prevention. And using all the costs that you see there in the table at the bottom right, they found that lenacapavir actually prevented the most number of HIV infections, but it was also the least cost-effective option. Interestingly, methadone alone, with or without cabotegravir, was the intervention that led to the highest number of life years and was also considered still to be cost-effective. So I encourage people to look at this poster once it's available publicly because I found it fascinating and again sort of speaks to how important cost is in implementation. Okay, so that is it. I think I didn't keep time, but maybe you all can save me.
Fine, Chase. Thank you so much. That was awesome. I'm going to share my slides and oh, does that look okay? Great. Okay. Thank you. Hello, everybody. I will be talking about treatment updates. I don't have any disclosures, and this is the outline of what I'll be sharing. There wasn't a whole lot, or very few rather, oral abstracts about treatment. Most of the sort of treatment data was in the poster presentations, and I chose to discuss long-acting cabotegravir and rilpivirine because I find that because these are relatively new medications, I think we have a lot of questions about them. And so I wanted to share those data. I will be giving an update on the CARES 96-week data. We'll go into some detail, and the rest will be a little bit more quick. We'll start off with the CARES study, which you might recall that last year I shared 48-week data from, and that was a phase 3B randomized open label active controlled non-inferiority study in sub-Saharan Africa at 8 different sites in Uganda, Kenya, and Tanzania, where adults who were on stable antiretroviral therapy and were undetectable were randomized to either oral ART standard of care or cabotegravir every 8 weeks. This was done in a public health approach to enrollment. I don't know the details of all of that, given that I do not work in the setting. However, the way that it has been described is that viral loads were checked every 24 weeks, which is every 6 months. And then during sort of enrollment, resistance analyses were performed during therapy, and proviral DNA was performed for archived resistance kind of retrospectively. So people were kind of just started on injectable ART, which is a slightly different approach than we do here. And this was very nice to see the results from, to see how it can go when people are not as stringent with criteria. These are some of the key baseline characteristics. As you can see, about a quarter of people or a fifth of people had a BMI greater than 30. This was a treatment experienced group where you can see the time on first line ART regimen was a median of 8 years. 75% of individuals had prior exposure to NNRTIs, and 90% of people were on an INSTI-based regimen at screening. Presumably, this was the combination of TLD, which is tenofovir DF, lamivudine, and dolutegravir. And then in italics, you'll see is the sort of archive DNA analysis, what they looked at retrospectively. And you'll notice that 55% of people had a viral subtype A1, about 7% of people had rilpivirine resistance mutations, and 10% of individuals had CAB resistance mutations. Now, this was significant because at 48 weeks, we saw that there was sort of non-inferiority between the rilpivirine and the oral ART arm. And this was significant because 50% of people had viral subtype A1. You might recall that initial data regarding virologic failure with rilpivirine indicated that perhaps having subtype A1/A6 virus increased your risk of virologic failure. However, with CARES, since we saw at 48 weeks that there was that it worked, even in the setting of 50% of people having subtype A1, I think most of us have now sort of acknowledged the fact that it's okay to have A1 subtype virus and that it's actually A6 subtype virus that is of concern. So I already shared that at 48 weeks, the meds were non-inferior, and this is 96-week data. This looks almost exactly the same as the 48-week data. And in fact, very, very similar. I had to do a double take multiple times to ensure that 48-week and 96-week data were in fact 2 different data sets because the numbers were incredible. So many people stayed in the study to 96 weeks, and this is how many people were virologically suppressed, which is amazing. 77% of people had an injection site reaction. Over 99% of people on long-acting Cabril preferred injectable to daily oral therapy, and 81% of participants received injections within the 7-day target window. When you're looking at how adherent people are to the injections, you'll probably notice that some of the data talks about how many participants received the injections in a window, and then how many injections were given in the window. And they gave both, but I decided to share the number of participants. And then there were 4 cases of virologic failure, whereas at 48 weeks, there were 2 cases of virologic failure. Here, there are, at 96 weeks, there were 4 cases of virologic failure with a failure rate of about 1.6%. And here is a little bit more data about those individuals. I'll go quickly through this and you'll see that there are 4 participants. The first 2 were from last year's study. And then here you'll see that participants 3 and 4 also failed between 48 and 96 weeks. I think the key sort of takeaway points from this image from their presentation is just that, you know, when people failed, they sort of developed rilpivirine mutations and they developed cabotegravir mutation. So when you do fail, that there is a sort of high likelihood that you will fail with relatively decent, or rather intermediate, rilpivirine resistance and cabotegravir resistance. So the failures are sort of important and significant, and so it happens. And so the conclusions are that at week 96, long-acting Cabril administered every 8 weeks in a public health setting was non-inferior in virologic efficacy to oral standard of care, had a good safety profile, and was well tolerated. We saw 4 cases of virologic failure in the Cabril arm with emergence of INSTI resistance and NNRTI resistance. And the CARE study, the reason why I wanted to go into these details and share about it is because this really remains an important contribution, not only to broad implementation in on a continent using a public health approach, but also in individuals with high exposure to NNRTIs with a relatively decent amount of pre-treatment resistance and different subtypes of HIV-1. So I was very thrilled to see the CARES 96-week data. Okay, now we're going to go faster. So key highlights from some CAB-RIL observational data, which was with the real world data. And there were the cohorts from the OPERA cohort that I wanted to share about, how viral suppression was in women in the OPERA cohort and viral suppression in the TRIO cohort. Viral suppression was great. I'm giving this away, but it's just nice to see kind of like what people did and how many people failed. So first in the OPERA cohort, of 2,600 persons with HIV on CAB-RIL, 83% were on it at the end of the study period. With a median follow-up of 11 months, 95% of people had viral suppression. And then after a median of 7 months, 1 person had confirmed virologic failure. Interestingly, 57% of people in this cohort failed within the first 6 months. So if people are failing, we're tending to see it early. I usually think about it in the first year. Viral suppression in women in the OPERA cohort was also great. Of 532 women who started CAB-RIL, 78% were on it at the end of the study period, with a median follow-up of 12 months. 94% had viral suppression, and about 1% had confirmed virologic failure. And then last, in the TRIO cohort of about 1,200 people, 79% were still on therapy at the end, and with a median follow-up of 12 months, 95% had viral suppression, and then 15 people had confirmed virologic failure. Of those, 5 of 15 had genotypic data. 3 people had failed with rilpivirine resistance, and you'll see that the 3 individuals had the following mutations. This is person 1, this is person 2, and this is person 3. And then one of those individuals, they did not say who, had also CAB resistance with the following 2 mutations. So great, we know CAB-RIL really works. I think what was interesting about this, and we didn't have really the reasons for this, is that there's a fair amount of attrition really by the end of the study period. And I think what I've learned in my sort of practice here is that, you know, being on CAB-RIL-pivirine isn't forever, right? Some people will go on to it and then some people will go off of it. And so I think that that's real life. Now, switching gears a little bit, what are the outcomes among people with HIV initiating CAB-RIL who were viremic? Again, very good. So the first poster presentation was from Ward 86 at UCSF, where 370 people with HIV were on CAB-RIL-pivirine, and 35% of those initiated with a viral load greater than 30. 97 or 98% achieved and maintained viral suppression at 48 weeks. And then they also compared viral suppression rates between those who were viremic at baseline and those who were virally suppressed at baseline, and there was no statistically significant difference. Again, recognizing that this takes a lot of resources that they used. At the Ponce Clinic at Grady in Atlanta, 361 people were on CAB-RIL-pivirine. 22% initiated while viremic, which they defined as greater than 50. You'll see that 70% of those people were on CAB-RIL-pivirine only. 28% were on CAB or rilpivirine plus len, and they had just 2 people on all of them plus ibalizumab. 92% achieved viral suppression. And of the 6 who did not achieve viral suppression, 2 had virologic failure with both NNRTI and INSTI-RAMS. 2 had persistent low-level viremia with viral loads less than 200, and then 2 had viral loads between 1,000 and 3,000, and even with multiple genotypes, there were no resistance-associated mutations. So again, some more real-world data about what's happening. What about CAB-RIL-pivirine in pregnancy? I know that this sort of comes up, and little is known about the safety, efficacy, and outcomes of CAB-RIL-pivirine use in pregnancy. And I know that we have dealt with this in our clinic, and I think we also just societally wonder about what is happening with regards to just any medication in pregnancy, volume of distribution changes, and there's especially concern about rilpivirine in the 3rd trimester. So I was happy to see that there was just a poster on this, and that it was a multi-center retrospective chart review of pregnant women prescribed CAB-RIL. 23 women received it during pregnancy, 11 were receiving it monthly, 12 were receiving it every 2 months. 73% of those people started it prior to pregnancy and continued it. And then, interestingly, 27% switched to it during pregnancy. Viral suppression at delivery was seen amongst 21 people who, or rather, sorry, 21 people stayed on cabrylpivirine to the end being delivery. 20 out of 21 of them had viral suppression. One person had a viral load greater than 1,000. And then, and I should also mention that most of these deliveries were vaginal deliveries. 81% of newborns received pseudovidine post-delivery, and there were no cases of vertical transmission. So their takeaway was that, this is a potential treatment option in pregnancy. We know that people have used this in pregnancy. However, they said, and there were good outcomes, but we need a lot more data with regards to safety, efficacy, PK, etc. And then the last sort of thing that I thought was interesting were two poster presentations about people stopping cabrylpivirine. As I mentioned in the sort of first sort of cohort studies, that some people come off of cabrylpivirine. It's not a forever medication. And that here you'll see that they got some data on why people stopped. So the first sort of information came from Ward 86, again, where they did a retrospective chart review, this time of 437 people with HIV starting rilpivirine. You'll notice that the numbers have increased from the prior poster I shared. They have more people on it at the time of this poster. And the median time on treatment was 553 days. So what's nice about this is that, this is, I had to do that math, but that's, a decent amount of time, and over a year, close to 2 years. And so people have been coming off of it. And in fact, 16% of people stopped treatment. 30% of those were on Q8-week dosing. And among those who started virally suppressed, the most common reason for discontinuation was pain. And among those who started viremic, lateness of injections and or virologic failure drove discontinuation. And so here is a table from their poster about their reasons for discontinuation. And if I can just draw your attention to this first column, just overall of the 69 people that discontinued treatment, you'll see that the sort of biggest issue was injection site pain or injection site reactions, or sort of injection site pain with other side effects and concerns. And then they sort of go through here all the other reasons why they may have stopped. And again, I just think that this is helpful real world information to see what people are doing. And then the other sort of why did people stop cabril paper, or so rather presentation, came from the Owen Clinic at UC San Diego, where they similarly did a retrospective chart review of their 465 patients on cabrylpivirine. Median time on treatment was 164 days, so shorter than the Ward 86 data. 20% of people stopped treatment. And then of those people who stopped treatment and were sort of switched back to oral ART, greater than 90% of those who restarted oral ART had viral suppression. Before I sort of talk about this last bullet point, which I think is interesting, I'd like to direct your attention to this table where they, again, went through reasons why people stopped long-acting Cabril. And here you'll see again that the sort of majority of people stopped because of injection site reactions. And then again, there's all these other reasons why. But I thought what was interesting is that one person developed NNRTI resistance during their PK tail. So, at baseline, the person had a viral load of 44, no resistance. They received 2 injections, they received their loading dose, and then unfortunately were lost to follow-up. They reestablished care after 9 months, and when they reestablished care, they had a viral load of 36,000. At that time, the clinicians sent or ordered both a genotype and a proviral DNA, and the genotype showed a Y181C, so like high-level NNRTI resistance. And then interestingly, the Y181C was present on the proviral DNA, but so was other NNRTI resistance. I just thought that was interesting. That was in a small little blurb on the poster, and I just wanted to share that discrepancy. Okay, and then the last thing I want to talk about is the combination of doravirine and islatravir. This is going to be quick, as everything has been. So as a reminder, islatravir is a nucleoside reverse transcriptase translocation inhibitor called NRTTI. And I have shared some studies regarding islatravir in combination with lenacapavir, and it's also, as you can tell, being studied in combination with doravirine. And you may have all heard about this previously because prior studies with higher doses of islatravir resulted in declines in CD4 T cells and total lymphocyte counts, and which caused the FDA to sort of pause this. But then they found that this was not happening with lower doses of islatravir, and so now we're sort of seeing studies again with those lower doses, and specifically doravirine when combined with islatravir at 0.75 milligrams was not good for T cells. They found that at 0.25 milligrams, it was fine to proceed. So you may recall that there were prior studies called Illuminate A and B with the 0.75 milligrams. This is now data kind of essentially repeating that. They don't have cute names yet. And so this is these are the two studies repeating those essential studies, but just with lower doses of islatravir. So among 500 people with HIV who are virally suppressed on BF-TAF, randomized 2-to-1 to doravirine islatravir daily, oral, fixed dose combination versus continued BF-TAF. Viral suppression was high, greater than 90%, and DOR islatravir was non-inferior at 48 weeks. 2 people in the islatravir doravirine arm had a viral load greater than 200, but there was no treatment emergent resistance. And 2 people on islatravir DOR and 1 person on the BF-TAF arm discontinued due to decreases in CD4 T cells or total lymphocyte count. And then in the other study where they compared doravirine and islatravir to baseline ART, viral suppression was high again, and doravirine and islatravir was non-inferior at 48 weeks. 5 people in this arm had virologic failure, but there was no treatment emergent resistance. So in conclusion, I forgot to write week 96. Week 48 CARES data demonstrated that Cabril was non-inferior to oral standard of care in sub-Saharan Africa, that in observational cohorts of individuals on Cabril, viral suppression remained high, including in people starting viremic. Long-acting Cabril may be a viable option in pregnancy, but more studies are needed. And then in clinics with large numbers on Cabril, approximately 15 to 20% of people have stopped injections, mostly due to pain or injection site reactions. And then doravirine islatravir appears efficacious and safe at a dose of 100 milligrams / 0.25 milligrams in phase 3 trials. I'm done. Raaka.
Great. Thanks so much. I have big shoes to fill now to take it home. So let me start with sharing things correctly. Can I ask if that looks good to everybody?
I'm seeing presenter view.
Oh, interesting. Better. Great. Thanks. All right. So I'm going to close out with talking about co-occurring conditions, which is a little bit of a grab bag. I have no disclosures. And so what I chose to focus on for this presentation is some updates in HIV and TB, updates in ART and weight gain, and then updates in Hep B vaccination. So we'll just start with TB. So I'll cover the study Dolphin Moms, I think the best name of any trial I saw during CROI. And actually our own Dr. Sylvia LaCourse is one of the study chairs. And this looks specifically at tuberculosis TPT, so preventative therapy and or LTBI treatment for women with HIV. Active TB risk is highest during and just after pregnancy for women. And for people with HIV who are not pregnant, we now have the option of short course rifapentine-based therapies. So 3HP, which is just 3 months of weekly isoniazid and rifapentine with daily dolutegravir, and 1HP, 1 month of daily isoniazid and rifapentine now with BID, twice a day dolutegravir. And these we've shown have similar efficacy, promote increased adherence, and have fewer adverse events compared to 6 months of daily isoniazid. However, as Dr. Budak pointed out, pregnant women tend to be excluded from trials, and that was the case here. And in terms of the PK, pregnant women we know have lower dolutegravir troughs than non-pregnant. And so that has led both international and domestic organizations to recommend daily INH for TB preventative therapy in pregnant women with HIV. But there is clinical trial data that there might be increased adverse pregnancy events with 6H. So some countries like South Africa are saying actually just wait till postpartum despite that risk. So this study team looked specifically in the sub-study at the PK of dolutegravir in both 1HP and 3HP in pregnant women. So this was a phase 2 randomized controlled trial of 1HP and 3HP and the PK of dolutegravir. It's still an ongoing study in South Africa because they're also looking at safety outcomes, both maternal and infant. And they looked at women who were enrolled in their 2nd or 3rd trimester, and then they were randomized to either 1HP or 3HP. They all had to have been on dolutegravir-based therapy for a month or more with sustained suppression. The outcomes, the primary PK outcome was population plasma PK parameters of dolutegravir in either 1 HP or 3 HP arms. And then secondary outcomes were viral suppression, and then a PK study of daily versus BID dolutegravir with 1 HP or 3 HP. And so you can see in the study schema is that everyone, when they enrolled, was put on BID dolutegravir because of that PK lower trough concentration concern I mentioned. Then they were randomized to either 1 HP with their BID dolutegravir or weekly 3 HP with their BID dolutegravir. Then they get a day 0 level, or rather they're enrolled at day 0, then they get a day 1 dolutegravir level before they're initiated on any rifapentine. And they get a day 17 level, and then those in the 3 HP arm got a day 52 level. They did get 2 PK samples of the dolutegravir trough at 11 hours and 12 hours post-dose, and the first 25 participants per arm were enrolled in this PK sub-study. So this is a busy slide with a ton of information, but basically 50 women were enrolled, 25 in each arm. They were both mostly Black and non-Hispanic, had high CD4s and were virally suppressed. So what you see here is dolutegravir concentrations versus time on treatment in days. And then you see these dashed lines are different dolutegravir cutoffs. Adding to the confusion a little bit, there's no consensus on therapeutic concentrations in dolutegravir, but 158 has kind of been generated in the literature associated with viral suppression in non-pregnant people. So you can see, and remember, there's all these boxes because we have 11 and 12-hour dolutegravir levels. But I think the big things to look at are day 1, there's really no difference in concentrations between either short course arm. By day 17, there's a significant difference between the 1 HP and 3 HP, so both between arms, and they both had lower concentrations as compared to their own within arm day 1. But the other thing to note is that though there are these changes between the arms, they remained therapeutic. They remained above that 158. And the one exception is these circled dots that right at the bottom, and those represent 2 women with adherence challenges, and both were able to maintain or again become suppressed. So the conclusion from this slide is all had therapeutic dolutegravir levels except for those with adherence difficulties. And then this is where the team then did simulations in a PK model of what if we did daily dolutegravir. I think there's a lot of stuff going on here, but the critical thing is that that pink shaded area is where in the model with daily dolutegravir in either 1 HP or 3 HP, where you'd see that the patient became subtherapeutic. And so you can see in the 1 HP with daily dolutegravir, perhaps unsurprisingly, most of those levels are below the 158 threshold in that pink area. But in 3 HP plus daily dolutegravir, the majority are, and in fact, all of the levels are above the 158 threshold, so none in the subtherapeutic range. So the takeaways from this, in pregnant women with HIV, twice-a-day dolutegravir with either 1 HP or 3 HP resulted in appropriate dolutegravir levels and continued viral suppression. In simulation models of daily dolutegravir, levels were below the acceptable threshold in 1 HP, suggesting need for twice-a-day dolutegravir in pregnancy. But in 3 HP, all the troughs are above the acceptable threshold, suggesting that perhaps daily dolutegravir can be safely given with this regimen in pregnancy. And so there's ongoing enrollment of an additional 25 women on 3 HP and actually taking once daily dolutegravir, so not just the model with PK sampling. So to stay in TB and pharmacokinetics, so bear with me, I thought this was a really interesting poster that was presented that looked at co-administration of TAF and rifampicin or rifampin. And so many of you might know or have seen that FDA labeling recommends against the co-administration of TAF plus rifampin because of the concern of lower TAF levels. If you look at the OI guidelines and the tables looking at ART with TB therapy, they say monitor for treatment efficacy because there has been some prior evidence in healthy volunteers without HIV that actually intracellular tenofovir levels are sufficiently high and actually higher with TAF. And so this study actually demonstrated that point. So I thought this was really interesting. This was an open label 3-period sequential pharmacokinetic study in people with viral suppression who are on rifampin containing TB therapy and in their maintenance phase. And so they were initially on a TDF-based regimen, and then they had their concentrations drawn. Then they were switched to TAF plus rifampin, and then back to TDF only after completion of the TB therapy. There were 18 participants, all completed therapy, And the big takeaway is that the tenofovir diphosphate, or the intracellular tenofovir concentrations, were 5-fold higher during the TAF plus RIF administration as compared to TDF plus RIF and TDF only. So I think that is really reassuring for us as we think about prescribing rifampicin plus TAF for our patients. All right, so now we're going to switch gears altogether and go to weight gain. So as we all know, that I'm specifically focusing on weight gain on ART. There's some weight gain associated with ART initiation that's expected, so a return to health phenomenon. There's also now drug direct effects that we see, right? So there's signals for independent weight gain effects of second generation INSTIs plus TAF, with the greatest weight gain in combination, although true of each isolated. And this is true in both switch, so people on other regimens switching, or people who are ART naive and initiating. Why does this happen? We don't know. There's a lot of nice speculation and a lot more posters investigating why this happens, but general thoughts are that there are weight suppressive effects of efavirenz and TDF. So if that's what you started on and switched, might lead to weight gain. There's probably some sort of synergy between TAF and INSTIs, and I won't go into other mechanisms. I think the big practical questions are, is this weight gain reversible on ART specifically, and how? And we don't know. There's no definitive RCT data, although many of you, like me, have been waiting for the results of the DO-IT trial, just switch from INSTI plus TAF to doravirine plus TDF or TAF. It was just completed, and I think we're supposed to expect data later this year. I'll note that in a sub-study of the advanced trial where we really saw these signals really dramatically, there was, in a sub-study, the women who were switched from TAF to TDF as standard of care, while still maintaining their dolutegravir and lamivudine, lost about 1.6 kilos, although men did not. So again, there may be sex and hormone-specific issues here. And so I wanted to focus on a couple of posters really here. And so many of you may have heard of the Paso Doble study, many of the 2-drug regimen studies named after dances. So in Paso Doble, it was already presented at IAS last year that switching ART to either Dovato, dolutegravir 3TC, versus BF TAF in people with HIV with viral suppression, if switched to the 2-drug combination, that was associated with less weight gain. So there were 2 posters that I wanted to focus on that had takeaways that I thought were interesting out of Paso Doble. So in a subgroup analysis of clinically meaningful weight changes, so meaning more than 5% from baseline, significant lower proportions of people with HIV with significant weight gain in the 2-drug therapy arm occurred in females, people who were aged 35 to 50 years, Latin American ethnicity, people with a baseline higher CD4 count, and people who were previously on TDF, FTC, and in an RTI containing regimens. So again, signals we've seen before. And then what about body composition changes? There were significant increases in fat compartments and decrease in lean mass compartments in all groups, but the changes were greater in those who switched to BF-TAF versus the 2-drug dolutegravir 3TC. And again, the use of TDF and efavirenz at baseline was associated with a significant difference in visceral and total fat mass changes. What if we switch from 2-drug dolutegravir 3TC to big TAF FTC? Do we see weight gain? In the INSTINCT study, no. And that's all I'll say about it. So that's interesting that I think we already saw if you were on something, switch to 2-drug therapy versus 3-drug, more weight gain with 3-drug. In this case, switching from 2-drug to 3-drug, addition of TAF to the INSTI made no difference, at least at 48 weeks. And then a rapid fire weight gain, some more posters. What if you were on an abacavir containing 3-drug regimen? So abacavir, lamivudine, dolutegravir, and you dropped the abacavir. Did that change anything? No. What about body composition changes in people switching from or maintaining TDF-based regimens? After 2 years of follow-up in this poster, TDF maintenance was associated with a slight reduction in BMI and total lean mass, where switching to TAF was associated again with an increase in BMI, but stabilization of lean and fat mass. And then finally, what about extreme weight gain? What about people who gain more than 10% weight within 5 years? And so again, things that were associated in this cohort with that level of weight gain was younger age, a higher baseline CD4 to CD8 ratio, switching to TAF, and then there was a trend towards this higher weight gain or extreme weight gain in people switching off TDF. So I know that was a lot of rapid fire information, but I think we're really adding to our bank as we are with most things nowadays with what's happening when we change ART. So It's multifactorial. We have more and more evidence that initiation of TAF plus a second generation INSTI is associated with more weight gain than an INSTI alone. There's some synergistic or additive effect, but interestingly, switching from an INSTI alone to a combination of TAF plus INSTI does not appear to drive further weight gain. TDF continues to be associated with some attenuation of metabolic and mass effects. And then what do we do? So far outside of the scope of this talk, we don't know. I think there's a lot of interesting discussion we've discussed before about addition of GLP-1s, thinking about strength, functionality, and not just BMI or other imperfect metrics of weight. Okay, so the last thing we'll talk about is Hep B vaccination in people with HIV. So again, I encourage you to refocus and restructure, total change in subject. So we've talked about the Beehive study before. And so just to remind you all, this was a study looking at the use of Hep B CPG versus Hep B alum, the conventional Hep B vaccine in people with HIV, with the idea that seroprotection rates in people with HIV for Hep B are lower than others. And so Arm A, as a reminder, was for Hep B vaccine non-responders, people with HIV who had not responded to previous vaccination. They were given either 2 doses or 3 doses of Hep B CPG or Heplisav, or they were given 3 doses of the Hep B alum. And then in Arm B, people with HIV who are Hep B vaccine naive, they were given 3 doses of Hep B CPG or Heplisav. And then the results have been previously presented in Arm A, those with vaccine non-response. People with HIV who are previous non-responders achieved superior seroprotective rates with CPG, and that was dose dependent. So 3 doses achieved a high proportion of SPR with surface antibody titers greater than 1,000. In the vaccine naive arm, 100% of people with HIV who received 3-dose series of Heplisav achieved a seroprotective response. Remember, that's greater than 10. And 84% in the 3-dose arm had surface antibody titers greater than 1,000. 98.5% achieved protective response after 2 doses, though at relatively lower titers. So only a third got to above 1,000 with 2 doses. So this data was what happens in terms of durability. So what does the data look like at 72 weeks? So in group A, what I want to point out is that this is people, I think that the big takeaway is you can see that there's high levels of surface seroprotective response, right? 97% in the 3 CPG arm, 86 in the 2 CPG arm, and then a much worse 57 in the 3-dose alum arm. But I think the interesting thing is who lost their serologic response after initially achieving it. And that was only 2.1% in the 3 CPG arm, 10.7% in the 2 CPG arm, and 22% in the 3 alum arm. And then what about in group B, the vaccine naive group? So there's 2 curves because group B vaccine naive is overlaid on the 3 CPG arm in group A. And you can see again, end of study, surface antibody titer was quite high, 97% had achieved that. And the durability here was quite high as well. So primary SPR proportion was 100, and then end of study was 97.3. And then this is a busy figure, but I like it because it's almost like a heat map of who achieved what degree of surface antibody titer. Because I think one question is, we've asked before, is it worth vaccinating up to a much higher surface antibody titer? And what this shows is that higher primary surface antibody titers were more likely to lead to the protective response by end of study. So 100% of those with titers greater than 1,000 at their primary response maintained a seroprotective response. Conversely, 0% with titers less than 100 in the 3 alum arm at primary response maintained that. 61% with titers less than 100 in the 2 CPG arm maintained it. And there were not enough people with titers less than 100 at the primary response in the 3 CPG arms to say. So takeaways here, in people with HIV, higher end of study seroprotection was achieved with Hep B CPG over Hep B alum. And among the CPG group, 3 doses over 2 doses. Hep B CPG or Heplisav led to durable seroprotection in both vaccine naive and prior vaccine non-responders. And again, how do we make our decisions? I'll note among many caveats that low CD4 counts and HIV viremia were not well represented in the study. So that's something to consider when talking to patients about 2 versus 3 doses. But to some extent, higher antibody titers means higher durability. And so our take-home points from 3 pretty disparate topics: in pregnant women with HIV, twice-a-day dolutegravir with either 1 HP or 3 HP was favorable from a PK perspective, and daily dosing of dolutegravir with 3-HP might be. There is increasing data that ART-related weight gain is complex, and we need more data regarding the impact of a regimen switch. And finally, Hep B CpG is superior to conventional Hep B vaccination in people with HIV and is highly durable. All right, that I'll stop my share so everyone's back.
That was fabulous. Thank you to all three of you. The evaluation link is there, but there are a few questions in the last few minutes. I know that you answered some of them already in the Q&A box, but there is one from Matt Messerschmidt. The 2024 IAS USA guidelines noted high rates of false positives for RNA testing in CAB for PrEP, as discussed today. They now recommend point of care HIV testing along with standard 4th gen antibody antigen testing, but they don't clearly define an algorithm of what to do with a reactive point of care test. Presumably point of care testing would have even higher rates of false positives than RNA. Has anyone developed a clear plan for follow-up testing? This one's for you, Chase.
Yeah, not that I know of. And if Joanne Steckler's on, she may be aware of changes that are coming, well, had been proposed for updates to the PrEP guidelines, which is not clear if those will be coming out as planned. But I do remember that Rafi Landowitz at CROI last year presented data on different combinations of HIV tests. So like, using point of care tests with an antigen antibody or point of care, two different platforms. And it seemed like the positive predictive value was better when you combined different tests. So I think that's sort of the best approach, like not relying on a viral load, but getting, either two different point of care tests if you can, or a point of care plus an antigen antibody, maybe on different platforms. And then what I took away from the conference was that, it takes sort of adjudication by, a group of people. So sort of thinking about the totality of all the results and making the decision from there. But I don't know that there's a clear algorithm, because it really also depends on like how long someone's been on CAB too, and if they've had missed injections, et cetera. So it gets complicated quickly. So we don't have one at UW because we just don't have very many people on CAB, but I recognize it's a clinical conundrum.
Thank you. A couple other questions regarding hepatitis B. Do we know if loss of a documented antibody response is associated with increased clinical risk for Hep B infection in a non-endemic setting?
Okay, that's a great question. I don't know of like large cohort data sets, but I know we've had anecdotal reports of that happening even within our clinic, and then talking to other providers at outside clinics. I think probably, but I don't know to what extent.
Thank you. And then another one for you, Raaka, about TAF and 3HP. Did the TAF and rifampicin study investigators venture to speak on implications for TAF and 3HP?
And that's a great question. And I asked it of the poster presenter for the TAF rifampin and didn't get a great answer. There was kind of like a, we'll explore. And I think that's probably the correct answer. But yeah, I think eventually if we extrapolate that to people who are not pregnant, it stands to reason that we'll extrapolate it further to pregnant women as well and say maybe it's okay.
All right. Well, thank you three so much for that super high yield talk. And it's really amazing that you go and you are able to distill the highlights of that meeting in such an awesome way for us to take home points here that could apply to our clinical practice. So we really, really appreciate it. I know it's a lot of work to do that. And yes, so we all appreciate you. Thank you so much. And to our attendees, please make sure to fill out the evaluation in the link and have an amazing day. Thank you all. And that was perfectly on time.